Close to 300 million vaccines have been administered in the U.S., and like other medications, some people are experiencing side effects after getting inoculated. But doctors are particularly concerned that some of these rare side effects, such as blood clots, appear to be more prevalent in women under the age of 50. So Dr. Joia Crear-Perry is an OB-GYN and the president of the National Birth Equity Collaborative, and she joins us now with some more insight on how women are being affected by these vaccines. Thank you so much for joining us, Doctor. The most dangerous, but also very rare, we want to point that out, but it's a significant health concern, the side effect that's reported in connection with the Johnson & Johnson vaccine. These are blood clots, a particular type of blood clot. The majority have been found in women under the age of 50. Do we have any idea why younger women seem to be affected, and whether or not there's a possible connection to birth control use?
No, right. Thank you so much for having me. So right now, we don't know why this is happening. We do know that women in general are more likely to have blood clots, especially the hormones that are in progesterone and estrogen that we create when we are having our cycles is more likely to increase our risk of blood clotting. And we also know that the way that this virus works is that it causes your blood vessels to be harmed, but we don't see a link. We don't have data yet to show why the vaccine would cause blood clots.
Doctor, as you know, earlier this week, the CDC walked back some remarks from its director, Dr. Rochelle Walensky, after she said the agency recommended pregnant women get the vaccine. The CDC clarified, saying pregnant women have the choice to get vaccinated and should consult with a health care provider. What would you recommend to a pregnant patient?
Well, the American College of OB-GYN recommends that pregnant people get the vaccine. So it's important for us. So I think the CDC was hoping that we could encourage that. We want to make sure that all people recognize that it's safe and it's important, even if you're breastfeeding or if you're not breastfeeding, that you still should be able to get the vaccine, because we have not found that it causes harm. But the CDC was just being extra careful to say, we're not encouraging, we're not telling that you should, but the American College of OB-GYN says that we should. So that's what I would follow, the recommendations of my organization, to say, yes, that pregnant and lactating women should get the vaccine.
So, Doctor, we want to sort of take care of any sort of misinformation or any questions that people may be pondering and going to social media to get the answer. So what about women who are trying to get pregnant? Is there any evidence that getting a COVID-19 shot has any impact on fertility?
No, we have not found any evidence that it impacts infertility. In fact, we're hopeful, because we do know that because the actual virus causes blood vessel damage and your blood vessels actually support fertility, we want to make sure that you don't get the virus. So the vaccine is important for you to actually, we're hoping to protect fertility. So no, the vaccine has not been shown to impact infertility.
Some women have reported getting their period soon after being vaccinated. Others say their menstrual flow was much heavier than usual. What do you think is the reason for this, and have any of your patients reported similar side effects?
Not any of mine, but yes, I've heard that quite frequently. And, we don't do a lot to really just look at what are the impacts on women's health from our hormones. The U.S. doesn't spend a lot of money on researching things like fibroids and menstrual cycles. And so I'm not surprised that we haven't yet gotten a lot of information around this vaccine when it comes to our cycle, because we don't have a lot of information about cycles in general. But we know that there are women who are reporting that their cycles are longer, or they get it earlier. And so we just want to make sure that we study that more. It hasn't been widespread, but there have been quite dozens of people saying that they have.
I'm really happy we have you here today, because I'm going to switch the topic a little bit off of COVID, but it's good to have you here. We're going to talk about birth equity. A recent study by The Lancet found that Black women are over 40% more likely to have a miscarriage than white women. Earlier, we spoke to one of the co-authors of that study, and she listed a variety of factors. Some of them are sort of obvious, like the health of the mother and the health of the father, but then there were external factors like stress having an impact on whether or not you're able to sort of to carry a pregnancy to full term. What do you make of those findings? Because that is a huge increased risk for Black women. And what needs to be done to tackle this?
Yeah, I was not surprised. Unfortunately, we know that Black women are 3 to 4 times more likely to die within a year of having a baby. We also know that Black women have higher rates of having preterm births, having a baby that was born too early prior to being full term. But we also recognize that translates into miscarriage. And to have studies that really show that the impact of racism, of gender oppression, the impact of our bodies dealing with all day, having to navigate spaces and not be valued and not be listened to. We know the stories of Serena Williams. We know the stories of famous people. And imagine if you're not famous, you're not wealthy, how that impacts your body and your health. So what we would like to see happen is us to end structural interpersonal racism. I know I'm saying it very flippantly, but that's really what's going to improve the lives of everybody, truthfully, because we're all being harmed by a belief in a hierarchy of human value based upon skin color. What even shows up in our ability to maintain and hold a pregnancy. So having the authors come on and talk about these risk factors, and also saying it's not just that our uteruses are not different shapes. We don't have different linings or different blood, kidneys, or lungs. All those are things that were inside of medical literature for so long that were deeply racist and based upon a history of white supremacy. So all those things are harmful. What would be helpful is for us to say, we're going to address the stresses of, paid leave, not having access to childcare, not having access to healthcare for all. All those are things that would actually improve outcomes, birth outcomes, and decrease miscarriage rates.
Doctor, it's so heartbreaking to read a study like that in The Lancet, and also see a study, some data that was published by the OECD Health that found in 2018 there were 17 maternal deaths for every 100,000 live births in the United States. That's a ratio that is more than double that of most other high-income countries. I find that remarkable in the United States of America. It just sort of boggles the mind. I mean, are there ways to address this rate, and are you seeing any incremental change at all in the last couple of years? This data is from 2018.
Well, we were even excited to get that data. I was honored to be able to testify in front of Congress for the only bill under the last administration that was passed to provide funding to CDC for counting maternal deaths. But prior to that, the United States had not done an official count and released it to the public around the number of maternal deaths since 2007. So you could see where our numbers could increase because we weren't even really tracking it. We were kind of guesstimating it and not investing in even valuing enough to look at the numbers at the city and the state level to provide funding for that. So it's exciting that we're starting to look at the actual counts, but when we look, it shows that we're still doing really poorly. It also shows that Black women who are college educated are 5 times more likely to die within a year of childbirth than a white woman who's college educated. So this is an issue that we cannot buy or educate our way out of. So if the language is going to continue to be that Black women or Black birthing people need to go to school, get a job, get an education, go to prenatal care, the data shows that even when we do all those things, that number that you showed of 17 per 100,000 is double, triple that for Black women. So we have to undo the harms of not having access to, like I said, equal pay, paid leave. The countries that have better outcomes than us, when you look across the world, they have things like free health insurance. They have things like access to childcare. So when we medicalize it as an OB-GYN, when we say we're going to fix the maternal mortality rate by making doctors better and getting more technology inside of hospitals, we're ignoring the reasons that other countries have better outcomes because they have doctors. We have great doctors here. We spend a lot of money on health care. What we don't spend money on is supporting people and investing in people and making sure that people have this social connection and the things like access to doulas and midwives and birth centers. That's the kind of thing that the other countries that have better outcomes than we do have invested in. So I'm optimistic that this current administration is really going to look into that and invest in that and ensure that we have opportunities to have reproductive and sexual well-being and health.
Yeah, I mean, when you look at countries in Europe, for example, the Netherlands, here's that statistic for that country. The maternal mortality rate ratio was 3 per 100,000 or fewer in European countries like the Netherlands, like Norway, or in countries like New Zealand. And here we are, the richest, most powerful country in the world, and we're looking at numbers of 17 maternal deaths per 100,000. Doctor, thank you so much for spending some time. Sorry, Anne-Marie, go ahead.
Doctor, you said something to me that made me think about just exactly how pregnancy is treated in this country, and that at times it is treated sort of in the same way as an illness. And because of that, there there, and the way we treat illnesses here is that we treat them once you are ill. There's not a lot of preventative care. And so there needs to be sort of a philosophical shift in, how pregnancy is approached before, during, and you point out when you talk about maternal deaths, it's not just during childbirth, it's in the year afterwards. So before, during, and after, how are we caring for these mothers?
Exactly. We need a community of well-being. We need a community of respectful maternity care. That's what we're working on, valuing people, whether they want to birth or not, how they want to birth, is seeing them very differently. That birthing is not a medical illness. It's not something that we need to hyper-medicalize, and that's what we've been doing in this country for the last 100 years. So it's time to stop. Since the beginning, once we got rid of brand midwifery and moved to this medical model, we've seen our outcomes get worse and worse. So how do we really value women's bodies, their choices, and ensure that they have the birth experience that they can thrive?
All right, Dr. Crear-Perry, thank you so much. We really appreciate it.
Thank you for having me.